HIV testing includes several stages, which would include screening, confirmation, and monitoring. Screening is performed using enzyme immunoassays or rapid antibody antigen tests. Confirmation previously relied on Western blot, but newer algorithms use different assays. And for monitoring, CD4 counts and viral load are essential. Understanding when each test applies helps us to guide diagnosis, treatment initiation, and follow-up. HIV screening is recommended for high-risk groups such as IV drug users, pregnant individuals, persons with risky sexual practices. Previously, this had been stated as men who have sex with men, and those with recurrent infections. The CDC now advises routine HIV screening for all patients seeking primary care, regardless of perceived risk. This approach normalizes testing and helps to identify asymptomatic cases earlier, improving outcomes and reducing transmission. The most common screening method is ELISA, which detects antibodies to HIV-1 and HIV-2, as well as the P24 antigen. Rapid tests are available using saliva or a finger stick blood and provide results within minutes. A positive screen is automatically repeated and followed up with confirmatory testing. Importantly, informed consent is no longer required before testing, allowing HIV screening to become part of routine care. Rapid HIV tests are qualitative assays that detect antibodies to HIV-1 and HIV-2. They're used as initial screening tools, providing same-day results without the need for a venipuncture. Advantages will include immediate counseling and reduced lost follow-up. However, because rapid tests may yield false positives, confirmatory testing, typically with EIA or nucleic acid testing, is always required. Enzyme immunoassays, or EIAs, are quantitative tests that detect antibodies to HIV-1 and 2 by measuring color change after antigen-antibody bonding. The antigen is coated onto a microwell, and when patient's serum contains HIV antibodies, a secondary enzyme-linked antibody, ELISA, produces a colorimetric signal. The intensity of color reflects antibody concentration. Some EIAs can detect both antibodies and a P24 antigen, which reduces the window period between infection and serologic detection. After several incubation and wash steps, a positive reaction produces a measurable optical density using an automated reader. Because the test is sensitive, even minimal antibody presence yields a actual detectable color change. This sensitivity, though, comes at the cost of some occasional false positives. So all EIA positive samples require confirmatory testing. EIAs are widely used because they integrate easily with other laboratory workflows, and they can also be run alongside routine chemistry panels. The Western blot historically served as the gold standard confirmatory test for HIV, as it detects antibodies to specific viral proteins such as GP41, 120, 160, and P24 on a cellulose strip. A positive result requires reactivity to key envelope and core proteins. And despite its accuracy, the test is costly, lab intensive, and sometimes subjective to interpretation. Many labs have transitioned to newer confirmatory methods, such as HIV differentiation assays or nucleic acid tests. The Western blot, though, identifies antibodies to multiple HIV antigens, confirming the infection after initial positive screen. Because of the variable performance and cost, though, it's no longer recommended in CDC testing algorithms. Modern two-step testing starts with a combination antigen antibody assay, followed by an HIV 1-2 differentiation test for confirmation. This newer approach shortens diagnosis time and identifies acute infections earlier. I've mentioned the P24 antigen, and it's a viral core protein that becomes detectable before antibody production. Measuring P24 helps identify acute HIV infection during that early window period. Because antibody tests may be negative at this stage, antigen detection provides a bridge between exposure and seroconversion. Many modern combination assays simultaneously detect both HIV antibodies and P24, improving early diagnostic accuracy. This is looking at a CDC recommended HIV testing algorithm for the first or fourth generation antigen antibody combo immunoassay, second an HIV 1-2 differentiation assay, and third, if the results are indeterminate, an HIV 1 RNA test. This sequence minimizes false positives and detects acute infections earlier than older methods. Understanding this workflow and other similar workflows is essential for interpreting lab results and providing timely patient counseling. HIV typically presents as a mononucleosis-like illness 2 to 6 weeks after exposure. During this time, antibodies may not yet be detectable, leading to false negative ELISA results, which this window is called the window period, and it lasts roughly 3 to 6 weeks. If recent exposure is suspected, repeat testing after several weeks is advised. Early identification allows for prompt initiation of therapy and prevention of further transmission. We talked about the P24 antigen, but the P24 antigen test detects viral proteins approximately 10 to 20 days after infection, often, like I mentioned, before seroconversion. It's really helpful in diagnosing pediatric HIV, where maternal antibodies complicate serology and blood bank screening for high-risk populations. However, though, P24 detection requires a sophisticated amount of equipment. It also has limited sensitivity once antibodies bind the antigen, which is why a combined antibody antigen assay is preferred. This is looking at essentially after diagnosis, HIV management, and monitoring, and how it focuses on monitoring immune function and viral replication. And our key laboratory markers are going to be CD4 T lymphocyte counts and viral load, as these parameters guide treatment initiation and assess therapy effectiveness. A drop in CD4 count or rising viral load will suggest or signal treatment failure or disease progression. And you can kind of see here, this is the point of infection. This is showing when you'd see these antigens and RNA and antibodies increasing. This is kind of showing from a detection perspective when you could see things, and this is showing kind of once we've established our HIV infection. This is showing the fusion of HIV with the host cell surface, how it then can get inside, move into the nucleus, and then essentially be using its reverse transcriptase be made into viral proteins and then released. CD4 lymphocyte counts can help determine prognosis and guide antiretroviral therapy decisions. Um, CD4 counts and viral load are not interchangeable. It's important to note that because CD4 reflects immune status, while viral load reflects viral replication. And we do need to interpret both together to manage patient care effectively. A normal CD4 count is in the range of 600 to 1500 cells, while a count less than 400 indicates disease progression and less than 200 defines AIDS. Testing can be done manually or via flow cytometry. And remember that a CD4 count fluctuates with stress, illness, and diurnal variation, so trends are more informative than just a single value may capture. Lymphocyte immunophenotyping will measure both CD4 and CD8 subsets, and it calculates the ratio between the two. Normally, it should be about 2 to 1. In HIV infection, the ratio will reverse to less than 1, and a CD4 count often is dropping, and it will CD4 count below 200 marks really severe immunosuppression and an AIDS defining stage. Monitoring all these values helps to evaluate the efficacy of therapy and detect treatment failure early on. It's important to note that CD4 testing does not diagnose HIV at all. It only monitors disease progression. When we come back, we will transition to types of TB testing.